Wonderful, thank you. And I so appreciate the invitation to talk with you all this morning. What a year we've lived, all of us. And I wanted to give you a little bit of overview of just what we've learned over the last year. I'm going to hit a couple of highlights of some of our cancer data, but really want to spend the bulk of the time talking about where we are certainly from a disparities perspective at this point in the pandemic, and some opportunities to engage with that going forward. So first slide here, obviously we'll talk a little bit about some of our cancer trends, and then reflecting on our COVID-19 experience to date in Tennessee. And then I want to talk about really some cross-sector gaps that we are urgently working to address, and absolutely appreciate the partnership of everyone on this call, and we'll hopefully give some additional opportunities for partnership by the time we finish. So next slide, please. So some cancer trends in Tennessee. Next slide. The few slides that you'll see here are reflective of our cancer data to date. Our cancer registry and our hospital discharge data take some time for processing, and so that's obviously not through 2020, it's through 2017, which is when we have the most recent data for cancer mortality and morbidity in the state, and certainly comparing it to the United States. And then what we see here is pretty obvious. Our cancer incidence rates in Tennessee and the United States, thankfully, have gone down over the last 10 years of data that we have readily available. But what we're seeing is a widening gap between Tennessee cancer incidence, which is now persistently higher than national incidence. And a lot of reasons for that that I think we're all well aware of, but we'll look at both some racial and geographic disparities over the next couple of slides. Next slide. So cancer mortality here, and again, what we're seeing is a widening gap. The good news that both Tennessee mortality in the blue and the United States mortality in the red have gone down, certainly over the last 3 decades. But that gap between the progress in the United States versus Tennessee is significantly greater in the US compared to Tennessee. Next slide. And then racial disparities in cancer incidence in Tennessee, and we're going to look at the mortality data next. But the top line there is male incidence of cancer in Tennessee, which has been pretty flat from the last 5 years of data that we have, 2013 to 2017. And on the green on the bottom is female incidence, and so lower incidence of cancer across all females. And then looking at Black and white incidence, again, combined male and female are those middle 2 lines there. And again, pretty flat for the state. Next slide. This is disparities in cancer mortality. And here we do see a decrease overall in male mortality. And then when we break that down, and female mortality, that's not a statistically significant difference in female mortality, but it is in male mortality. And again, that Black and white combined for male and female are trending downward slightly. And those are the middle 2 lines from a mortality perspective. And Black mortality, which we're seeing in the light blue on the top, just under the red line, is significantly higher than the purple white mortality, which is the purple line, kind of second from the bottom. And next slide. And this is our geographic disparities. So when we look at disparities kind of from a state data perspective, we look at race, age, gender, and place. And so obviously rural versus urban here, both in incidence at the top and then mortality at the bottom. And we see both from an incidence and mortality perspective that incidence is higher in our rural counties, as is mortality in our rural counties. And next slide. And so where do we go from here? We've made some pretty intentional efforts with the additional availability of some state funding and federal fundings to particularly address disparities that will, we believe, impact cancer disparities as well as all-cause mortality. So that has included the expansion of safety net funding for both primary care and for specialist care. If you're not familiar with how the safety net funding works in Tennessee, we, in addition to federal funding that comes to federally qualified health centers, we as a state also provide additional funding for federally qualified health centers, as well as community faith-based clinics. Over 100 of them across the state. And they are funded in 89 counties, which will be expanded to 95 counties with an additional RFP this fall. And then we also have focused specialist care coordination and project access you're probably familiar with in the Nashville area. There are project accesses that focus on that specialty access in Knoxville, in Northeast Tennessee, and in Chattanooga. And that project access funding, again, specialist access, is now being funded in Memphis and West Tennessee, and we funded all of those project access for a specialist access care coordination and really referral networks to really expand out from the metro areas into the rural areas. It started actually in fiscal year 21 and will be expanded further in 22 and going forward with recurring funding. We've also increased state funding for loan repayment programs, particularly focused on those health professional shortage areas. Similarly, you have likely heard about additional residency programs that have been funded by the state legislature, and particular recruitment efforts on those from minority and rural backgrounds, knowing that those individuals are both more likely to stay in those service areas, as well as have an element of real trust, and which ultimately results in better outcomes for those individuals who are from minority and rural backgrounds. And then for all health professionals, we've expanded implicit bias training. This has started actually in our maternal mortality program areas, because that's where we had funding for initially, and then expanding more broadly to certainly partner with many of you on the phone who are offering that training, and then to offer that ourselves, both internally and externally. And then I'll talk a fair bit about, I think one of our biggest lessons learned is really a focus on data dissemination, both on our data capture and in making sure that race and ethnicity and geographic location are captured up front in our data, that it's good data, and that infrastructure is what we've really focused on building through COVID-19, or improving that in COVID-19, and then obviously expanding that with data dissemination through community groups, weekly meetings with our minority health engagement group, which is an open public meeting weekly. And then obviously, given the really lack of seeking treatment and seeking access to care, we're really focusing a lot more messaging on that makeup screening and opportunities for individuals to kind of catch up on health maintenance and to think about health more intentionally than they may have thought about that pre-pandemic. And next slide. So our COVID-19 data is some of what I'm going to focus on over the next few slides, and we can go ahead and launch into that. So we in public health, I love this slide from Dr. Kamara Jones. I think she speaks so well to the role of all of us in addressing health disparities. And from us in public health, we really see our role in all of these areas. Certainly in addressing social determinants of health, also in those primary prevention efforts, smoking prevention, and obesity prevention, and then in access to care, both in what we do from a safety net perspective, as well as what we do from licensure and regulation, and quality improvement, and the medical care and tertiary prevention. And certainly COVID-19 was no exception to this. We have had a significant role in that social determinants in really how do we address COVID-19 in the homeless population and school populations, and getting kids back to school in an equitable way to address long-term disparities. And then in primary prevention, that messaging around masking and now vaccination and making sure that that is getting to communities effectively and in an equitable and community engaged manner that really centers communities in that messaging. And then, of course, in safety net access, both for treatment and testing of COVID-19 and then in vaccination, first in our safety net clinics before it was available in any other clinical setting. And then obviously in that medical care, we had a significant role in hospital capacity. That my role shifted entirely to hospital capacity and what we were doing with COVID-specific nursing homes to offload hospitals, as well as in regulation and access to as many healthcare professionals in the broadest sense possible that were coming into the state, and then really seeing new roles within our state. Next slide. So this is where we are. From a case perspective, we obviously saw a tremendous surge in July, which we struggled with in July in the summer. And then to say that we struggled then pales in comparison to that surge that we all have quite not distant memories at all. In December and into early January, we reached our peak. From a hospital capacity perspective, January 6th, which just briefly was preceded by the peak in cases in January. And then where we are now is not back to where we were spring of last year. We're certainly getting closer and managing that in a very different way. And our hospitalization trends have followed this trend from a case perspective pretty closely over the last year with about a week or two delay. Next slide. So overall, where are we from a mortality perspective? This is to date rates of death by state. And we are about the middle of the pack. We were fortunate that we did not see the early surge that a lot of states saw that dramatically impacted nursing homes, certainly in New York and New England. We were able to learn from that, and I think that really spared us a lot of mortality in the state. And you know, I feel like we as a country certainly could have done a lot better, as a state could have done a lot better. And at the same time, we had a lot of wins, certainly in our elderly population. And then from a race ethnicity perspective as well. And so next slide. Obviously, COVID-19 has paralleled from a death perspective, the incidence of chronic disease. And so that slide that you saw just a minute ago is to many degrees reflected in this incidence of chronic disease. Our cancer mortality maps look a lot like this as well. And so, you know, we have an undue burden of, or a disparate burden of chronic diseases in this state. And I think that certainly is reflected in our mortality data as well. Next slide. So diabetes, among those chronic conditions, has been shown to be the best predictor of mortality, followed by COPD and malignancy. And next slide. Looking at really the impact of diabetes, and we see that certainly in the western part of our state, in rural parts of our state. And so these are mortality rates for COVID-19 at the bottom, which again, parallel that diabetes map that you're seeing at the top there as well. And so again, our rural populations, western populations are where we have seen the greatest disparity of COVID-19 mortality as well. And then next slide. Looking at our racial and ethnic disparities, that map at the bottom there is actually available on our website, and I'm sorry it's blurry in this presentation, but it is looking at mortality rates, and we have also incidence rates and hospitalization rates by race and ethnicity on our website. If you click on there's a place for look at data here, and then our special populations data. And we have data for child populations, for maternity populations, and then by race ethnicity in a similar graphic there. And overall for the state, about 13% of our total COVID-19 cases have been reported for the Black and African-American Tennesseans. That's compared to 17% of the Tennessee population. And then among our Hispanic population, about 6% of our Hispanic population I'm sorry, 6% of total COVID-19 cases for the state are among our COVID-19 or among our Hispanic population, whereas 5% of our Tennessee population is Hispanic. Early on in the pandemic, this was not the case. So we saw a much higher burden of both cases and mortality in our Black and Hispanic population compared to the Tennessee population. And it did quite a bit of really engagement in communities and faith communities in particular, in really understanding what messages were most important in locating services, testing, and now vaccination in those in those communities, really to bring resources to the community itself. And the data that we're seeing here, which is more reflective of the overall population of those race ethnicities, really is a tribute to those communities being at the table and really them being at the center of this response. Next slide. So then how are we doing with vaccination? Here you see the darker is better. So our higher percentage of vaccination are in the darker blue counties. And so nationwide, about 60% of the country's population has had one or more vaccination dose, whereas statewide, we have definitely seen a lag in uptake for vaccination. And although the vaccination now is very readily accessible, in rural counties, the uptake is significantly behind. And you can see kind of our counties with the least uptake are on the left, and those are largely rural counties. We've done quite a lot of work in focus groups on what messaging is going to work. There's a new campaign that was launched both for rural and minority communities in the past weeks to really try to build trust. The access is there, the trust and willingness to take vaccine is not, so the demand is not there. And so we are, again, working very hard with community partners to address that disparity from both a geographic perspective, and then the next slide is going to show you from a race ethnicity perspective. So if we could go to that next slide. And so this is our uptake among Black populations for those who have received at least one COVID-19 vaccination. And saw a significant uptake really February, March. Again, that statewide comparison is 37%. And so 25% of Black Tennesseans have received at least one COVID-19 vaccination. And we've seen that, again, significant uptake and then a leveling off. So significant work to be done there. And then our next slide is in our Hispanic population, if we could show that. Next slide, sorry.
Did it not go?
It paused. Well, it would have been the Hispanic population, which really has been paralleling the Black population. So the numbers actually look very similar in the Hispanic population. The uptake was a little bit delayed, but similar, very significant uptake. And among Hispanic populations, it's actually 28% that have at this point received at least one dose. So next slide. Okay, there we go. So the long-term impacts of COVID-19 are unknown. There are some positive glimmers. Actually, our infant mortality rate seems to have decreased significantly in 2020, and we're digging into that. But the bad news slide is in front of you. So as of our provisional 2020 vital records data, we at the close of December had an excess mortality of about 10,000. So it's a 14% increase for the state of Tennessee. And that only includes about 5,000 of our COVID-19 deaths. So the bulk of our deaths have actually been in 2021. So about 5,000 of those were in 2020. And again, over 12,000, almost 13,000 deaths total in the state from COVID-19. COVID-19 was the third leading cause in the state, and you likely have seen the NCHS reports that is similar nationally. But we did see an increase in multiple causes of death. So an increase preliminarily in cancer death, preliminarily in heart disease, stroke, people not able to access or willing to access or seeing the signs and seeing an urgency in access of care. And then violent death is up significantly in 2020. So homicide up 16%. And then when we break that down to youth homicide, up 38% from 2019. And again, this is provisional data. A lot of reasons for this, certainly mental health, I'll talk about in a minute. Kids being out of school, certainly unrest globally. We were not spared from that in the state. And then our overdoses are up by at least 22%, 2019 to 2020. Next slide. So from a youth mental health perspective, what you're seeing here is month-to-month comparison of ER visits across the state for suicide-related ED visits. So this is youth who had suicide ideation or suicide attempt. And then month by month, you see a comparison. The left within each column, the left is 2019 and then 2020 data, and then 2021. We obviously have that data through April, and then the beginning of May. All of May is not counted yet in that data, but what we see is a significant increase from 2019, particularly into late 2020 and early 2021. From a youth mental health crisis. That's certainly been in the media. It will increasingly be in the media. But the resources that have to be deployed to schools, and now that it's summer, to community-based settings, to faith communities, to community health workers, is something that we are mobilizing very quickly to our partners in the mental health sector, and then across the healthcare and community sector. Next slide. I'll go quickly through these. The next few slides are just the big picture overview of, although we're looking at mental health impact, that is a microcosm, obviously, of the overall impact for COVID-19. Huge job loss, significant burden to women in particular. Next slide. And then those who were able to go back to the workforce, those jobs have more quickly come to those outside of minority communities and outside of women. So women in minority communities have had more intense unemployment and longer unemployment. Next slide. Some of that has certainly been impacted by school access, and women certainly have had the burden of remote schooling disproportionately. Next slide. And then remote instruction has exacerbated particularly disparities in educational access. This was data at the end of last school year. It's going to be, I'm afraid, much more dramatic at the end of this school year as we have that testing availability. But what we've seen is really educational gaps across the board, race in all individuals, but particularly impacting Black and minority populations even more than white populations. So next slide. And that virtual instruction was a piece of that. So Black and Hispanic students were twice as likely to have no access to in-person education as white students, and that's national data. Next slide. And unemployment, we know traditionally has followed educational achievement. And so addressing that educational gap is going to be critical for addressing the employment gap, which is going to be critical for addressing the health gaps. And what you're seeing here is unemployment rates, highest unemployment for those who have less than a high school diploma, big spike there in 2020. And then those who have a bachelor's degree or higher is in the red, and obviously a lower level of unemployment across the board and within the pandemic, certainly notwithstanding. Next slide. So this is the big picture where we are from an unemployment perspective. 37% of the Tennessee workforce has faced unemployment. So over a third of Tennessee has been unemployed at some point during 2020. We've made massive gains in that. And at this point, we've got a 5% unemployment rate, which is down from 15% a year ago. So nationally, we look a lot better from an unemployment perspective than the rest of the country. That's a piece of significantly good news. And then next slide. Where that unemployment has been, so lowest unemployment really in our Mid-Cumberland area, highest unemployment still as of March 2021 in our rural areas. And next slide. So where do we go from here? Again, that data transparency and accessibility, we were one of the first 3 states actually to have data by race ethnicity for both testing and for vaccination. And that was not nearly quick enough to get that to communities. But the overhaul that has, the opportunity that's created in really overhauling our mass vaccination data infrastructure, our testing and disease reporting infrastructure to be able to even report race ethnicity. And that's been a burden to those community providers that are reporting into that system, but has been absolutely critical from a response perspective to be able to get that weekly to our community engagement stakeholders, to get it to folks like you all, to be able to develop plans both for responding to this pandemic, as well as to respond to those educational, economic, and overall health big picture needs that we have as a state. We are having increasingly, you can go back to that slide. I'm actually going to skip that next slide, but our workforce recruitment, we are putting massive amounts of federal funding into that workforce recruitment and retention. And then that health professional engagement and training, and then shoring up our infrastructure for families and community support, because what we are able to focus on in children is going to impact for generations. Again, their educational achievement, their economic access, as well as overall the disparities that we will see downstream from a health perspective. So next slide. This is just where we are as a mission and vision, prevention and access, with equity being a core piece of that values. And next slide. So a few ways to engage. If you're not already engaged in our Minority Health Disparity Task Force, it meets every Thursday from 1 to 2 p.m. We show this data regularly. And if you want to engage in that, just minority.health@tn.gov, we'll get you that link. And then the Our Voices campaign we launched over the last month, which really reflects the voices of communities, and particularly minority and rural communities in the COVID-19 pandemic. And again, centering those stories is a key piece of what we're doing to be able to elevate the voice of communities on our social media for others to be able to tag into that. To highlight those voices of really what the pandemic has been like, as well as success stories of where we have been able to engage with communities and share ideas for furthering successes. And next slide. You'll see a couple of grant opportunities coming out over the next couple of months, particularly focusing on community health workers that going to both healthcare settings as well as non-traditional care locations, so faith groups, particularly focusing on social determinants like housing, and then some technical assistance through our county health councils to be able to mobilize the $7 billion that is coming to the state of Tennessee, often to local and community governments, and how do we mobilize that effectively over the next couple of years from the American Rescue Plan. And next slide is where I'm going to wrap up, and I'm happy to take any questions by email or certainly via the phone, but again, very much appreciate your inviting us to participate in this conversation.
Thank you so much, Dr. McDonald. It was a pleasure learning about several initiatives from administrative perspective and healthcare initiatives, public health initiatives. Thank you so much. In view of time, we can only entertain one question. If you have any questions, please unmute yourself and identify yourself and ask the question. Just one question, please.
Hello, this is Dr. Linda Clayton. I'd like to thank Dr. McDonald for an extremely comprehensive and just weighted presentation. Clearly, a lot is being done here in the state of Tennessee. Could you just give us a few sound bites, a little bit more about your efforts to train and recruit minority professionals to address the issue of cancer? Are you looking at specific institutions? Are you looking at pipeline issues? Just a few sound bites on how you're going to make that happen.
Thanks so much, Dr. Clayton. You've certainly been very instrumental in our efforts as the state health department and a state more broadly in addressing disparities and in thinking about workforce for sure. So thank you for that. So we are looking at a couple of opportunities really to address health disparities from a workforce perspective across multiple avenues. So just to give an example, the work that we are going to be funding from a community health worker perspective, obviously having trusted voices in the community is essential to healthcare delivery and healthcare access. But we are investing in community health workers, not just to hire for the short term, but also to train those individuals and provide opportunity to allow them to move into licensure should they choose to do that, whether it be social work or nursing or physician training. So obviously drawing from the community to then build that healthcare workforce across disciplines. And then also targeting things like state loan repayment to rural and minority applicants, and looking at institutions in all three grant divisions to be able to do their own recruitment, again, across health sectors to engage in that spectrum from community health worker to licensure and beyond. So we've had a number of conversations and have a grant contracting process in the works as soon as that funding is awarded to us to be able to get funding immediately into all three grant divisions with pilot institutions from both HBCUs as well as from state-funded institutions in that workforce recruitment and then deployment.
Thank you so much.
Again, thank you so much, Dr. McDonald. It was a pleasure having you here, and thank you for spending your Saturday morning with us. It was an honor to have you. Our next speaker, Dr. Wingfield. Dr. Wingfield is a radiation